So I thought of, good morning to all of you. Good morning. So I thought of organizing this neurological examination for the candidates who are going through the PACES exam, because I have found during my examination that the weakest station for our candidates are, one is the neurology and second is the talking stations, especially the communication station. These are the two places where we pull down our candidates. Because the neurology is just like mathematics. See, if you have some signs, they are there. You cannot guess or you cannot say plus or minus. That is the difficulty with the neurology. And in the examination, you are getting only 5 minutes for the neurological examination. But the advantage here, you have been asked to do a focused neurological examination. In neurology, there are only a few things you have to know. That is, first of all, you should localize the lesion. Once you localize the lesion, it's very easy for you to find out a few etiological differential diagnosis, and then you can plan the relevant investigations and then management of the case. So in the exam, we will ask you, where is the lesion? What do you think, what could be the etiology for this lesion? And how will you investigate her or him? And how will you manage? So you get about 5 minutes for the clinical examination, and then another 5 minutes, 1 more minute we will give you for just recollecting your presentation, and then 4 minutes we will have a discussion. Okay, now coming to the, now I'm starting with the lower limb neurology. Okay, usual this presentation of a case is, we will say this patient has difficulty in walking, so please do the relevant neurological examination. What you can do is, you can ask the examiner whether I can see his gait. If they agrees, that means either he has got an ataxic gait, or he has got a Parkinsonism, or he has got minimal residual weakness only in the lower limb. But suppose if the examiner says no, he cannot walk, then you know he has a paraplegia. Either it's a spastic paraplegia or a flaccid paraplegia. So from that clue, you can get an idea how to proceed further. Now, in neurology, there are two things. Either it could be upper motor neuron lesion or it's a lower motor neuron lesion. So you have to recognize either upper or lower motor neuron lesion first. Upper motor neuron lesion in the lower limb means the corticospinal tract is involved. When the corticospinal tract is involved, what are the signs you will look for? 1, the limbs can be weak. 2, the tone will be increased in the form of a spasticity or hypertonia. 3, the reflexes will be exaggerated. And 4, the plantar will be upgoing. Plus or minus sensory deficit depending upon the site of the lesion. Okay. So what you should do is, you should do a brief inspection of the limb before starting the neurological examination, and make sure that the patient does not have any pain in the limb, especially if a patient has got a very swollen knee joint, and if you are going to look for the tone without asking whether you have any pain anywhere, you may fail in the exam, in spite of you doing the best neurological examination. So make sure before starting the examination, ask the patient, do you have any pain anywhere? And make sure that he doesn't have. If he has pain, a swollen knee joint with painful joint, then you can tell the examiner, I'm going to be very gentle with this patient because he has got pain in the right knee joint. Okay. Now, if inspection is very important, and if you, while inspecting the lower limb, if you see marked wasting in a weak muscle, in a weak limb, then upper motor neuron lesion is ruled out. Because corticospinal tract lesions will not produce any marked wasting. Wasting will not be produced by any corticospinal tract lesions. So if you see marked wasting of the either anterior compartment muscles or the feet muscles or the thigh muscles, then you are sure that this is not going to be an upper motor neuron lesion, it could be a lower motor neuron lesion. So it could be either a peripheral nerve, peripheral neuropathy, or it could be an antidepressant disease in the spinal cord. Then you can proceed further. Now you have it inspected. you haven't seen any abnormal wasting. So the next task is to see the tone of the muscles. So the tone of the muscles you can do like this. Okay, this you compare with the other side. You are sure this is symmetrical. Then you can do just where they lose a just see this. This you have to be very careful if he has a knee joint problem. Okay, so I have seen this and it looks normal, the reflex tone for me. Now along with this, you can, if the patient has a normal tone or hypertonia, then along with that you can do the angle clonus. Okay, along with that. So the angle clonus will make sure that you are supporting the calf muscle, the gastrocnemius, and then a jerk, a sudden jerk over the ankle with a dorsiflexion that will produce the angle clonus. If the angle clonus is present, then your task has become very short because you know he has got a corticospinal tract lesion with a hypertonia and spasticity. So I am sure that this patient may be having a spastic paraplegia, or it is if it is one limb, it could be a part of the hemiplegia. Okay, suppose if this patient has got a flaccid limb and you are suspecting marked wasting is there, and if you are suspecting a polyneuropathy, there is no meaning going and doing an ankle clonus. That means you are not thinking about it. I get really irritated sometimes. The candidate is wasting time in a very markedly wasted lower limb, and it looks like that he has got a very polyneuropathy, and still you are going for the ankle clonus for what? There is no corticospinal tract involvement in that case. So if the tone is normal, okay, or equivocal, you are not sure whether it's hypertonia or normal tone, or if the patient got a spasticity, then you can go for the ankle clonus, and that makes you easier, because even in the presence of the ankle clonus, even if you are not looking for the ankle jerk, we will not penalize you, because when the ankle clonus is there, definitely 100% the ankle jerk will be exaggerated. Only one situation you have to be careful. When the patient has got a marked spasticity, this gastrocnemius muscle will be spastic. Okay, so when you are eliciting the ankle jerk, there is nothing for the ankle gastrocnemius to contract. So there will not be any contraction, and so you may label it as negative. Ankle jerk is absent in the presence of an ankle clonus. This is ridiculous. If you say like that, you will fail in the exam. Because when there is an ankle clonus, you are sure this patient has got a corticospinal tract lesion and the ankle jerk will be exaggerated. This absence not because of the anything, but because of the gastrocnemius is already contracted state. So after, by tapping the tendo-Achilles tendon, you are not going to elicit any more contraction of the gastrocnemius, so the ankle jerk can be absent. So that is why I am saying, if you elicit an ankle jerk clonus, then there is no need for you to go and tap the ankle jerk. The examiner is not expecting you to do that. Even if you don't do that, you can say because the ankle clonus is there, so sir, I expect that the ankle jerk will be exaggerated. Now, coming to the corticospinal tract lesions, the hypertonia occurs in the more powerful muscles than the weaker muscles. There is a peculiarity in the corticospinal tract lesion. The anti-gravity muscles are more powerful than the other group of muscles. So you can see the upper limb, the shoulder adductors, the elbow flexors, wrist flexors, and the finger flexors are more powerful than the opposite group of muscles. So the hypertonia develops in this group of muscles. So what will happen? The shoulder will be adducted, the elbow will be flexed, the wrist will be flexed, the fingers will be flexed. This will be the posture in a corticospinal tract lesion. In the lower limb, again, the hip extensors will be more powerful, the knee extensors will be powerful, the plantar flexors and inverters will be more powerful. So what will happen? The limb will be extended, the plantar flexed foot. So that produces the circumduction in a hemiplegic movement, a hemiplegic patient. So this is about the distribution of the hypertonia in a corticospinal tract. Now you have looked at the tone of the muscles, and now your next task is to find out the power of the muscles. Power of the muscles, you can look for the hip flexors, the hip extensors, hip adductors, hip abductors, then the knee flexors, knee extensors, the dorsiflexors, plantar flexors, and inverter and inversion. Inverters and inverters, we are not expecting you to do that in the neurological examination if you suspect a corticospinal tract lesion. But if it is a peripheral neuropathy in a locomotor neurosis, you have to look for that. Now, coming to the neurology of the lower limb, a little bit about that you can put that lower limb. See, there is a little bit of knowledge of the neurology or the nerves of the lower limb is needed. As all of you know, the lower limb is supplied by the highest nerve root is L1. L1 is the highest nerve root. There are two plexuses which supply the lower limb. One is the lumbar plexus, okay, and the sacral. Lumbar is L1 to L4, and the sacral is L4, L5, S1, S2. These are the two plexuses will supply. Most important nerves from the lumbar plexus are, one is the femoral nerve, okay, that is L2, 3, 4. Then comes the obturator nerve, L2, 3, 4, and then the lateral cutaneous nerve of the thigh. These are the clinically important peripheral nerves from the lumbar plexus which supply the lower limb. The femoral nerve, L2, L3, L4, the obturator nerve, L3, L4, lateral cutaneous nerve of the thigh. Now comes the sacral plexus. Sacral plexus, there is gluteal nerves, L4, L5, S1, gluteal nerves, which are supplying the gluteal group of muscles. They are the hip extensors and abductors. Then comes the sciatic nerve. Sciatic nerve, the tibial nerve, and the peroneal nerve. Okay, that is L4, L5, S1, S2. All the roots of the lumbar plexus will be involved in this one. Then comes the posterior cutaneous nerve of the thigh. These are the three nerves you have to remember in the sacral plexus. So the femoral nerve supplies the hip flexors and the knee extensors. Okay, the adductor, the obturator nerve supplies the adductors of the thigh. The gluteal nerve supply the abductors as well as the hip extensors. Okay, so even without touching that region, you can check for the hip flexors. See, this is the hip flexors. This is L2, L3, L4. Then keep your hand down. This is hip extensors, L5, S1. So hip flexors are L2, L3, L4. Then continuation, hip extensors, L5, S1. Okay. Now abduction. Abduction. This is abduction. This is L4, L5. Adduction. L2, L3, L4. So this is L2, L3, L4. This is L4, L5. This is L1, L2, L3, L4. Then hip extension is L5, S1. So the hip is over. Now comes to the knee extension. Yeah, this is hip extension, knee extension. That is again L2, L3, L4. So here this is knee flexion. That is L5, S1. So this is L2, L3, L4. This is L5, S1. Now comes the dorsiflexion. L4, L5. This is S1, S2. S1, S2. Okay. So these are all continuous actually. You know, this is L2, L3, L4. Hip flexion. Hip extension is L5, S1. Okay. Adduction is L2, L3, L4. Abduction is L5, S1. Knee extension is L2, L3, L4. Knee flexion is L5, S1. Okay. Dorsiflexion is L4, L5. Plantar flexion is S1, S1, S2. Eversion and inversion. Inversion is by L4 nerve root, where the eversion is by S1. So this is inversion and this is eversion. Okay. So these are the muscles which are briskly you can we are not expecting you to a detailed examination of the muscles. At least you should know the hip flexors, hip extensors, hip abductors, hip adductors, then the knee flexors and knee extensors, the dorsiflexors of the ankle, plantar flexors of the ankle. This is enough. Inversion comes only in the peripheral neurons. Now comes the reflexes. The reflexes, there are only two reflexes in the upper limb you have to see. That is, you keep it like this, okay, very relaxed, and then most of the people I have seen in the exam doing like this. This is not the right way of the recitation of the angle jerk. You can be very bold and you feel the patellar tendon and then tap it like this, okay, and look at the quadriceps for the contraction. Note here, the quadriceps should be looked at for the contraction, okay. You can compare both. Don't do this one and go to the ankle, but compare either side to look for the asymmetry. Now comes the ankle jerk. Ankle jerk, you make sure that the gastrocnemius is not contracted, it is relaxed, and then not very full extension you should not do like this. This is a wrong way of technique, the wrong way of eliciting the ankle jerk. You should medium, just slightly, and then see. You can just tap it like this, you can elicit. So most of the people I have seen doing like this and then tapping, nothing will be there because already the gastrocnemius is contracting. So you should be very careful, make sure that the patient is comfortable, just do like this and just slight dorsiflexion and then tap over the tendo-Achilles tendon. So this is L2, L3, L4, the knee jerk. Main root is L4. Okay, and this one, ankle jerk is S1. S1. Now comes the plantar reflex. Plantar reflex is an important clinical sign you should never forget. And most of the people are making mistakes in plantar elicitation. The root value of the plantar is L5S1. L5S1. So you just keep it like this and then hold it like this and just scratch the lateral part of the sole of the foot. See, the lateral part of the sole of the foot. Okay, here. And you can come here, but you should not go to the flexor aspect of the toes. So you can start the scratching from the lateral part of the sole of the foot, and then you can come like this. So what happens in the normal flexor response, as you start scratching here, there will be a little bit of contraction of the tensor fasciae lata, a little contraction of the adductors, and then it will start the plantar flexion of the outer toes, followed by all the toes will be drawn inside at the metatarsus, and there will be a dorsiflexion and inversion, dorsiflexion and inversion. That is what happens in a normal flexor response. Okay, see, you can do like this. The initial movement is the outer toes, not the big toe. You understand?
Big toe is the one which we.
No, I am telling you, I am coming. This is the normal flexor response. Okay. The normal flexor response is like this. See, this is a withdrawal. That's a withdrawal. So this is also withdrawal. That's what I am saying. You have to be very careful when I listen. Now I am repeatedly scratching his leg. That's why he is going to this thing. See, the movement of the outer toes. Okay. In an extensor plantar response, what happens is when you scratch the lateral border, this big toe will first move. This is the first movement. First movement in an extensor plantar response, which is because of the corticospinal tract lesion, which is actually, it's a nociceptive withdrawal reflex of the Sherrington's decerebrate posture. So the first movement will be the big toe up, and then there will be a fanning up or dorsiflexion of the other toes, and then there will be a dorsiflexion of the ankle, then flexion of the knee and flexion of the hip. All this will happen. So as the extensor, the pyramidal tract lesion is becoming more and more extensive, the receptive area from here will increase to other areas of the sole also. And even if they may come up to the knee joint. That is why you do the open heave and Gordon's reflex, which are not reliable and we are not using it. So your task is to elicit the plantar response. If it is a upper motor neuron lesion, you just scratch the lower, the outer aspect of the sole and see the first movement of the big toe. If it is going up, you are sure this patient has an extensive plantar response, and that is confirmed. Now, abdominal reflex is there, which may help you sometimes, but we are not routinely asking you to do the abdominal reflex because it is not very reliable, because in multiparous women and obese people, it will not be very reliable, the abdominal reflex. So only in one situation you can use the abdominal reflex. Suppose if you have done the plantar and you are not sure whether it is extensor or it is mute or it is downgoing, you are not sure, then you can come and do the abdominal reflex. And suppose if this plantar is mute and this is normal, and I am not sure whether this is extensor or not, you come and see here. If this reflex is absent, then you know this is extensor. This is the only situation where you have to do the abdominal reflex. Otherwise, there is no role for abdominal reflex now in this rapid clinical examination. Okay. So that means
when you said only lower limb to be examined.
Yeah, but you can see. I am not sure about the plantar response. I would like to see the abdominal reflex, and you can just scratch it like this, and then you know if it is present, or if it is present, then you are doubtful. The lesion should be below, but below D12. It should be D12, but above L1. It's very difficult. So it's a very tricky situation. So this is only, but if it is absent in this side and this side it is present, then you are sure that this patient has got a corticospinal tract lesion. And then regarding the sensory system, actually if you suspect, at first you can do a sampling actually. This is L1, this is L2, this is L3, this is L4, and this is L5, and this is S1. So L1, L2, L3, L4, L5, and S1. So you can sample. If you want, you can sampling you can do. You touch L2, L1, L2, L3, then L4, then L5, S1. You can do the sampling first. Okay. After that, if you feel this patient has got a peripheral nerve involvement, then you should start from below. Can you? Got it. Yeah. You should start from below them. If you suspect this patient is going to have a peripheral neuropathy and a length-dependent way of loss of sensation, then you can start from below and tell him that I am going to start touching from here. Whenever you start feeling absolutely normal, you please tell me. Then you can start from below. Here like this, like this, like this, and then you tell him that whenever you feel normal, you please tell me. Then he will tell you, okay, this side I am perfect. Then you know this patient may be having a stalking type of peripheral neuropathy. Okay. So this is the way of the brisk examination of the lower limb.